You are live now, ma'am.
A very good evening to everyone here, and I welcome you to another session of DOS Super Tuesday initiative that we started this year. And every month we have dry eye clinics. And today we are going to have a very interesting and important discussion on ocular allergy and dry eye. We have with us Dr. Radhika Natarajan today to discuss this topic. She is the Deputy Director of Cornea and Refractive Services at Shankar Nethralaya, Chennai, and she has extensively published and presented at various meetings, and we have always learned from ma'am. She has been a mentor to so many of us, and she has a special interest in corneal infections as well as inflammations and wireless vision prosthesis. Thank you so much, ma'am, for joining us today, and we are really looking forward to learning a lot from you this evening.
Thank you, Aikida. Thanks to you, Dos and Dr. Praful for having me over here. I'll share my screen in a bit.
I also welcome our panelists, Dr. Abha Gaur, Dr. Rashmi Mittal, Dr. Annu Malik, Dr. Deepa, and Dr. Aditi Agarwal. Thank you for joining us, and thank you for being on the panel so that we can discuss this very important topic this evening.
Can you see and hear me, Dr. Aikida?
Yes, ma'am.
Yeah, so good evening, everybody. I'm Radhika from Shankar Nethralaya. I'm going to speak to you about allergic eye disease and its association with dry eye disease. The two important diseases that we see very often in the cornea clinic, how they are interlinked and how they are different. So these two entities can actually simulate each other. They can provoke each other in a background of ocular surface inflammation. So when you have allergy, the constant irritation and inflammation has its toll on the corneal nerves, on the meibomian glands, even on the lacrimal gland, and it can produce dryness. Similarly, when you have any form of dry eye disease, the washing out of the allergens and the washing out of the inflammatory mediators is inhibited, and therefore the allergic disease can also get exacerbated. So ocular surface allergy is a chronic bilateral seasonal inflammatory condition which encompasses a lot of diseases. But the common points are that these disease involves the tarsal and the bulbar conjunctiva. There can be remissions and exacerbations. Quite often allergies are not only self-limited, they are also limited to the ocular surface, as the name itself suggests, unless there are secondary complications. We know that, needless to say, the common entity is VKC or vernal catarrh, which occurs bilaterally in children between 4 and 7 years of age, and then proceeds from that point. Young males in hot climates are primarily affected, and it can be associated with other forms of atopy. Like these patients usually have allergic rhinitis or hay fever, asthma, skin eczema, etc. And the pathology is common to both the systemic and the ocular allergy, in which, as the pop-up diagram shows, the antigen comes in, it is processed by the antigen processing cells, and IgE response is stimulated, which then leads to degranulation of the mast cells, which sets up an inflammatory cascade, which then manifests as the classic allergy signs and symptoms that we see in the patient. So allergic eye disease, the commonest entities that we see are the seasonal allergy, which happens in spring or summer, which is a little mild. It's caused by type 1 hypersensitivity. It occurs very frequently. It leads to permanent allergic conjunctivitis. And the next grade is the vernal catarrh or the VKC, which is caused by both type 1 and type 4 hypersensitivity, which is a little more severe. More severe than that, caused by the same two types of hypersensitivity, is the atopic keratoconjunctivitis. This gradation is important because, as we shall see in the next slide, the treatment also needs to scale up according to this degree of severity. The last form of allergy, which is GPC, is actually misnamed as allergy because it is usually an inflammatory response to an inert kind of a stimulus. So here is how the treatment escalates in various forms of allergy, starting from the seasonal allergic conjunctivitis right up to the atopic keratoconjunctivitis. On the other hand, we have dry eye, which is divided in the simplistic algorithm into aqueous deficiency dry eye, where the tears are produced less. The main cause is old age, but the secondary causes can be Sjogren's syndrome. Or you can have evaporative dry eye where the meibomian gland function and lipid production, is deficient or low in quality, that the tears fail to stay on the ocular surface. Or you can have reduced wettability because of mucin deficiency, like in vitamin A disorders. So we saw a very brief overview of these two clinical entities which have a lot of symptomatic overlap. And what is the overlap and what are the differences? We'll see with some case examples now. So both dry eye and allergic eye diseases we know can present with redness, burning, blurring vision, sensitivity to bright light, even reflex tearing can happen in dry eye, and foreign body sensation, itching. These are all common to both the diseases. You can also have ptosis mechanically because of the weight of the papillae in allergic diseases, and the constant light facing difficulty also produces ptosis in dry eye. So, how to distinguish these two diseases? Ocular surface staining can help us to some extent. So, when you see this kind of bilateral, dull, lusterless staining in the interpalpebral region, then you tend to think of dry eye, because the reduced tear first affects the interpalpebral region and the apex of the cornea, because that is where the tear film is thinnest, and therefore one can encounter this kind of staining. Contrast this with allergic conjunctivitis. Here, the staining is not only on the ocular surface, but one needs to look at the staining of the tarsal conjunctiva or the bulbar conjunctiva as well. For example, take a look at the two pictures on top. Both the patients have similar looking papillae, similar looking allergy. But when you see the staining of the tarsal conjunctiva below, you can see that the left-hand side patient, the tarsal plate has stained very much compared to the patient right below, making it clear that the former has got a more severe allergy compared to the latter. And when this kind of papillary reaction rubs against the cornea, especially when it becomes giant papillae, the picture on the right shows you that you get SPKs. Here it's not uniformly distributed like dry eye, or it's not in the interpalpebral region, but it is more in the superior cornea where the rubbing actually happens. And in this particular patient, you can see the SPKs coalescing to produce a more severe keratitis due to the ocular allergy. So this is the type of staining you will see as the allergy progresses, as compared to this uniform and dull lusterless staining, which is seen bilaterally in dry eye disease. So an associated sign that may help you is this kind of pigment dispersion that you observe in allergic diseases. It is believed that the constant eye rubbing releases the melanocytes and they migrate onto the bulbar surface and sometimes even onto the periocular skin. And when you see this kind of pigmentary dispersion, it may give you a clue that though the symptoms may be common between the two, you're probably dealing with ocular allergy rather than dry eye disease. So we know that when dry eye is caused by an eyelid problem, when you have a meibomian gland disease, there is tear instability. Why? Because then it is a evaporative type of dry eye where the lipid is insufficient, either in quality or quality, and therefore the tear doesn't stay on the cornea very well. Can you have a breakup time or an instability of the tears in allergy also? Apparently you can. So we know that this is the classic form of vernal catarrh where you have papillae on the limbus, and you can have follicles around the limbus. And in the right hand side, you can see the picture of a blown up follicle bursting with inflammatory cells. So what are these papillae and follicles? Papillae are basically composed of a twig or many twigs of capillaries which are surrounded by inflammatory infiltrate. On the other hand, you have follicles which have clusters of inflammatory cells which are surrounded by blood vessels. And you can see in the right hand picture, when the disease progresses, these papillae and follicles can virtually become indistinguishable from each other. Added to this is, we know that when the disease is active, you can have aggregations of eosinophils which coalesce to form the Horner-Trantas dots, which you can see on the left picture. And on the right-hand side, the inset picture shows you the severe inflammation in the tarsal plate as evidenced by the fluorescein staining. And when this kind of giant papillae, they rub on the cornea, and you can get scarring in the form of pseudogeron toxon. So how does all this affect the breakup time? you must realize that all these are irregularities on the ocular surface, and they do have their effect on the tear surfacing. So in this patient, when we do the breakup time, we do see that similar to lipid disorders or meibomian gland disorders, here also you see random patches of dry spots and the breakup time being reduced. Here, paradoxically, you can also see that the tear meniscus is increased because of reflex tearing. Dry eye can many times have an autoimmune background. We know that especially in women who are in the above 40 or 50 age group, when you have dry eye, then you have to many times investigate them for a rheumatoid background. Can be associated with rheumatoid arthritis or SLE or such collagen vascular disorders. Can you have that kind of autoimmune background for allergy as well? Yes, because this is also an inflammatory disease. So certain types of allergy can also have autoimmune background just like dry eye. Take, for example, this patient with atopic keratoconjunctivitis. So this lady has got skin lesions in the form of maculopapular rashes in the skin of the elbow. She also has pustules on the eyelid and hypertrophic or hyperpigmented patches in the neck. So these have to be treated with the coalition of a dermatologist, because unless and until you get the autoimmune disease under control, treatment of the AKC will not bear result. And this is how the disease progresses. You can see the perilimbal papillae, the Horner-Trantas dots, the intense staining, which you can see in the third picture on the tarsal conjunctiva. And when the disease is just treated topically, half-heartedly, you can see that it leads to severe blinding corneal scarring as well. So there could be a trigger which is associated with both dry eye and allergy, and contact lens use is one of them. When you say contact lens related dry eye, actually the tears don't reduce. In the initial stage, at least, it is more because of a mechanical discomfort with the contact lens as well as a metabolic discomfort due to hypooxygenation. But over a period of time, the inflammation takes a toll and you can have a real dry eye as well. So we also know that contact lens similarly can be a stimulant for allergy as well. So on the left-hand side, you can see the typical giant papillae due to vernal catarrh, which are smooth and rounded and, next to each other. But on the right-hand side, you can see contact lens-induced GPC. Like I already told you, this giant papillary conjunctivitis is not a true allergy. You can see the differences in the appearances also, that compared to VKC, these are flat top, these are bigger, and these are more widely spaced because the intervening septae are larger over here. And this is not a true allergy, rather it is caused by the material of the contact lens or because of the solution that is used along with it. So it is a response to these inorganic substances that sets up this GPC. And other agents can be sutures or foreign bodies, which can cause a similar reaction. It's not a true allergy. And when you abstain or withhold the inciting agent, quite often the medication takes effect to cure this condition. So not only small triggers like contact lenses, you can also have extreme diseases which provoke both dry eye and allergy at the same time. Now we know that VKC is a disease of childhood or young adulthood. VKC in adult is uncommon, but when it happens like you see in the picture on the left. The small picture on the left shows you that there are flat-topped papillae, and in this particular patient, if you invert the lid and see, you won't have giant papillae, just fibrosis of the tarsal conjunctiva. So VKC in adults can sometimes happen because the patient has shifted the house or is exposed to agents which they were not exposed earlier. But typically, these lead to less corneal complications. But take a look at the picture on the right. This is an adult with VKC, but this adult also has HIV. So you can see the florid disease over there. And not only that, where you can see the keratinized patch underneath that is also a lurking OSSM. The constant rubbing and irritation because of the allergic eye disease in the backdrop of the immune suppression has led to this OSSM. So what actually happens in HIV? In HIV patients who are untreated, you have an imbalance of the T helper 1 and the T helper 2 cells. Th1 cells promote immunity. that is deficient in these patients, and therefore they are low in immunity. And because of that, the Th2 activity increases, and Th2 promotes allergy, and that explains this florid disease. Also, there is a two-prong method in which dry eye also sets in. You can see the low Schirmer wetting in the inset picture. This is one sometimes because of direct invasion of the virus itself into the lacrimal gland, and also the setting of inflammation, which causes the dry eye. So why is this important to recognize? Because all you may want to treat the dry eye with lubricants and the allergy with steroids, this is not going to settle down. What it takes is coalition with an internist to start the patient on antiretroviral therapy. Only when the Th1, Th2 balance equalizes and the CD4 counts come to normal, then your classic treatments may start taking effect in these patients for their dry eye as well as for their allergic eye disease. So we are well aware of dry eye causing ocular surface changes, especially in dry eyes which are associated with, say, Stevens-Johnson syndrome or chemical burns or other cicatrizing eye diseases. Can you see these surface changes in ocular allergy?
Hello.
You probably can. You can see the normal limbus in the... Pardon? Somebody is trying to say something? Otherwise, Aikida, I think somebody is not muted, so maybe you can tell them unless they're asking a question. Can I proceed?
Yes, please keep yourself on mute. I think Dr. Abhishek has joined us.
Okay, so that doesn't matter. Welcome, Abhishek. So we were discussing as to the ocular surface changes which were produced by cicatrizing eye disease in comparison with the ocular surface changes that are produced in vernal catarrh or allergic conjunctivitis. So you can see in the inset picture the normal limbus where you can see the worm-like appearance of the pigmentation with the vasculature. But see the pictures below. This is a case of chronic vernal catarrh. And you can see that the perilimbal papillae and follicles are starting to scar down. And as the disease progresses in the last picture, you can see that it has virtually taken hold of the limbus, causing a 360-degree limbal deficiency, much like a cicatrizing dry eye. It doesn't stop over here. Many recurrent attacks sometimes can lead to this kind of a picture where in the picture on both the extreme ends, you can see bulbar scarring. And in the picture in the middle, it shows you tarsal scarring, the two pictures in the middle, and also the picture showing the symblepharon because of prolonged vernal activity. Why is it difficult to know the history? Because when you ask the history, you know that this patient has had itching and this disease has started in childhood, and you know that these are sequelae to vernal catarrh rather than cicatricial eye disease. Why should you know the difference? Because if it is vernal catarrh, even though the picture may look like this, it's probably representing a worn out or a burnt out stage of the disease. The disease may not be any active right now, but if this is a cicatricial eye disease like your ocular cicatricial pemphigoid, then that means that the disease is very much active both in the cicatrization and in its dry eye component, and urgent treatment is required with immunosuppression and biopsy to salvage vision in these patients. So dry eye and allergy have a very close common friend in the form of herpes simplex virus. This is a patient who was referred to us. You can see the picture on the left. This is a patient who was referred to us for treated and burnt out allergic disease with corneal scarring for vision rehabilitation. But when you stain, you can see bits of dendrites hiding over there. And the fluorescent staining is mandatory even in quiescent eyes to bring it out. And rose Bengal staining can be complementary as well. And in the third picture below, you also see that the tear meniscus is reduced. So surgery is best avoided in these eyes, even though the eye looks deceptively quiet in the first picture. But if you have to operate to give visual rehabilitation, all the three components, the allergy, the HSV keratitis, and the dryness should be well under control before we put a scalpel onto these eyes. So both conditions of dry eyes and allergy produce a toxic milieu to the corneal epithelium. And many instances of SPKs can finally give rise to persistent epithelial defect in both these conditions. Here is a a patient on the left-hand side who developed a PED who also has dry eye disease. Some giveaway points are obviously the history. You can't depend on the tear meniscus over here because some amount of reflex tearing will be there. But dry eye disease related epithelial defect usually occurs in the central cornea because if you recall, we discussed that that is where the tear meniscus is maximum affected and it will have these rolled up edges and uniform dense staining of the base. On the other hand, dry eye disease patients, when they have associated rheumatoid arthritis or collagen vascular diseases, they can also develop peripheral ulcerative keratitis, and that needs to be differentiated from these central epithelial defects which are caused by the dry eye itself. Contrasted with the picture on the right, that this is a patient with vernal catarrh in whom also there is a persistent epithelial defect, but look at the location. It is in the superior cornea. Look at the edges. They are more rounded and elevated. And more important diagnostic factor is that there is a mucus plaque at the base. So this is a shield ulcer, which is caused by the vernal catarrh due to the papillae rubbing against the cornea. So we need to distinguish these two because when there is a PED due to dry eye, then you need to remove all toxic medications. You need to increase the lubrication. You can attempt punctal cautery and even tarsorrhaphy as measures to treat it. On the other hand, if it is a shield ulcer due to VKC, first of all, you need to debride that mucus plaque. Otherwise, the epithelium will not heal at all. You need to address the GPC either medically or surgically. And here you may need to institute steroid also as a treatment to resolve this shield ulcer. Unless all this bunch of treatments is tried, this is the way the shield ulcer will progress. You can see the giant papillae and the shield ulcer that it has produced and the secondary infection that has taken over, introducing a whole new angle to the treatment now. So not only in symptomatology and signs and history is there overlap between dry eye disease and allergy, you can have a lot of similarity and differences in the medical management as well. So needless to say, we give lubricating eye drops for obvious reasons for dry eye, but lubricants form an important stay of treatment in allergy as well because we need to wash out the allergens, we need to wash out the hyperinflamed tears and give comfort to the patient. Also, topical anti-inflammatory agents like cyclosporin and tacrolimus. I prefer tacrolimus a lot, which is used in allergic eye diseases, also have a role in inflammatory dry eye, where there is a lot of ocular surface inflammation. Not only we have common agents, sometimes we can have antagonistic agents because we give dual acting agents like which contain antihistaminics, which are of benefit in allergic eye diseases. But we know that both topically and systemically, when you give antihistaminic agents, these can increase or exacerbate the dry eye. So you need to work it out to a balance where you're treating both the conditions optimally. So it's not as though dry eye and allergy are, mimics to each other. You can have a third-party disease which can look like both. This is a simple disease where you see the blepharitis on the eyelid margin, which is a staph immune disease. And this can also set up a keratoconjunctivitis. And here you can have itching or rubbing because of the eyelid problem and also because of the meibomian gland deficiency, you can have dry eye as well. But this is not a classic allergy or a classic dry eye. And one small question helps when you ask the patient how they rub the eye. In these BKC patients, their eye rubbing is, back and forth. They go with a finger like that on the irid. Whereas in BKC patients, they roll their knuckles over the eyelids. And one look on the slit lamp at the lid margin also helps you elucidate this condition because all it takes is simple lid cleaning, maybe with a course of doxycycline, rather than thinking that this is allergic eye disease and pump the patients with steroids. This is my last and favorite slide where I'm going to show you a patient who was referred to us with intense papillae in the lower lid, and he was diagnosed to have severe allergic eye disease, but then the patient did not have any itching at all. So normally that is a red flag because whatever papillae you may have, no itching usually means no allergy. And the patient was staining uniformly on the corneal surface, which prompted somebody else to think that he had dry eye and he was on treatment for that also. But when we took a look at the cornea, we saw that there is some amount of corneal edema with old keratic precipitates, if you see keenly over there. Now, tracking back to what we said, unless there are complications, typically speaking, both dry eye and allergy are extraocular diseases. So we delved a little deeper into the history, and the patient gave a history of plant juice squirting into the eye. So now with that history and inferior papillae without any itching, inferior corneal staining, as well as a toxic response in the cornea. So this prompted us to believe that this is a toxic reaction to a noxious stimulus, rather than any simple dry eye or allergic eye disease. So sometimes we need to go a little deeper into the history and look a little holistically before making the diagnosis of dry eye or allergic eye disease. So with that list of differentials, I close my presentation. Thank you very much for having me over here. I am open to answering any questions both on the presentation and outside of that.
Thank you so much, ma'am, for a very insightful talk. I would like to start with asking a very basic question because there's a recent paper by Leonardi et al. Which they talked about that itching has always believed to be the hallmark of ocular allergy, but lots of times it's not a very specific symptom. The recent 2021 paper in which they talked about ocular allergy as well as dry eye, because sometimes dry eye patients had such diffuse symptoms that they can also complain of itching. So, because the last slide ended with itching, so I thought let's start with the first thing, which is the symptomatology of ocular allergy and dry eye. So, ma'am, in clinical practice, how often do we see dry eye patients also complaining of itching? What I have seen is that if there is allergy, there will definitely be itching, but itching can also be present in a few patients who have dry eye. So, how to differentiate, and is it a pathognomic symptom, or what else we should be looking at?
I think you answered your question yourself, and just like we also, projected with the patient in the last slide, allergies should always have itching 99% of the times, unless it is an allergy which has burnt out or worn out, and you're seeing only the secondary sequelae. On the other hand, all patients who have itching don't have allergy. We have all sorts of non-specific, conditions ranging from computer vision syndrome to dryness who can come with itching. So that is where the history of recurrences, the history of associated allergic disease, the clinical presentation not only of the papillae and follicles, but the pattern of staining. The pattern of staining which involves the not only the ocular surface, but also the tarsal plate and the tarsal conjunctiva, and the association with systemic allergies. All these can help you to get a diagnosis. On the other hand, if you take a dry eye disease, you may not have history which dates back to the patient's younger days. And in the early stage of dry eye disease, you may not have staining which involves the tarsal conjunctiva or the tarsal plate. And obviously, GPC or any papillary or follicular reaction or Horner-Trantas dots like pictures speak for themselves. So that is where the clinical appearance, the staining, and the history may help you to differentiate from actual allergy. But then the paper that you're referring to is also a starting point for the discussion that these two may not be as discrete as we believe them to. They start discreetly, but there is a lot of overlap, because when dry eye disease progresses, then at that time the capacity to wash out inflammatory mediators, the capacity to wash out inciting antigens reduces, and therefore that can potentiate allergy. And also when there is a chronic allergy, what starts off as ocular surface inflammation blunts the corneal nerves, infiltrates the lacrimal gland, infiltrates the ductus, and therefore it kind of winds up as dry eye disease also. So while the points that I told you are certain ready reckoners to distinguish the two, when the disease finally progresses, you may have to end up treating both the entities.
Right, ma'am. Thank you. Thank you so much for explaining it really well. I'll open the discussion to our panelists. Can we
Yeah.
have your comments and questions, please?
Yeah. Hi, Dr. Radhika, ma'am. Really nice presentation. I must congratulate you.
Thank you.
And thank you for sharing such useful insights with us. Ma'am, I just wanted to ask you one question that suppose we have started our treatment for the allergy and we have been giving patients steroid as well as antihistaminics and lubricants. So what should be the first step up for us when if the patient is not responsive for these treatments? Like should we go for a full strength steroid and or should we go for a oral steroid like oral immunosuppressant? I mean, how should we step up the treatment? That would be my
Actually, I'm quite
question to you,
glad that
ma'am.
you asked the question because there is a lot of homework that is to be done by us and by the patient before we escalate the treatment. Okay,
Yes,
because
ma'am.
we should know, and the patient also should know that dry eye is not like say fever or cough and cold where you give the medication or the disease kind of burns it out. It is a long-standing
Yes, ma'am.
process where the patient has to outgrow the disease, and some of them, a small proportion of them, don't outgrow it at all, even in adult life. So a
Yes, ma'am.
tailored
So
approach
they are
is the
very,
best.
very much concerned about till how much time
Correct.
would they need? Would
Correct.
they be
This,
needing the
we have to
drops?
turn back the
Yeah.
same concern on them that if you're going to have this disease till adulthood or beyond, then do you really want to exhaust everything that we have to give and incur the side effects in the early stage of the disease itself? So I believe in treating the patient rather than the papillae. What I mean by this is that
Yes, ma'am.
if the patient has got a lot of symptoms, they say this, that, and the other, but the ocular surface speaks otherwise. You're not seeing GPC, you're not seeing corneal involvement, you're seeing only a certain amount of papillae. And in allergic disease, quite often the symptoms and signs don't correlate. The patient tells you more than what the ocular surface tells you. In these conditions, we have to educate the patient on starting with basic measures like avoiding dust pollution to the best extent they can, giving cold water compression every single night. In my hands, when I educate the patient, it really helps because the vasoconstriction, gives a good start to the next day. There is a method of doing that. We educate to them that they use cold water, which is palatable, not tap water, drinking water, and also drinking cold. Some people have the habit of putting ice on the eye and they come with lid screen necrosis. So it's best that we demonstrate how to give the cold water compression. So avoiding dust pollution, giving cold water compression, and giving
And
dual acting
avoiding
agents.
rubbing.
Avoiding eye
And
rubbing is
avoiding the rubbing.
correct. Avoiding eye rubbing
Yeah.
is easier said than done because the patient will ask you right back that if I feel like rubbing, then what do I do? So you start with cold compression and avoiding dust and dual acting agents. So this is the best first step. If the patient follows this diligently, some amount of relief will be there. Second step is to ask the patient to maintain a logbook. Just like the residents maintain a logbook, the patient should maintain a logbook because many times, especially anxious parents of children will ask you, what is my child allergic to? What should I, you're telling me avoid. What should I avoid? Then you explain to them that allergy, generally speaking, to dust, house mites, etc., is good to avoid. But then every patient or every child is allergic to something different, right? So before going into a panel of allergic testing, they can maintain a logbook. What is this logbook? Which particular activity consistently, or which particular food stuff, or which particular place they visit. Okay, these are three things that they can document daily, and at the end of 3 months, if you review place, activity, food, will give you an idea as to what is a consistent trigger. So then you can tell them that this is probably a trigger and that is something that they can avoid. Of course, you can substantiate this with a panel of allergy tests more for the sake of inclusion rather than exclusion. What I mean by this is the panel divulges something to you, you're lucky. But if the panel doesn't divulge anything to you, it doesn't mean that the allergic trigger is not there. So that is the next step. So after that step of dual acting agents, if the patient is supremely symptomatic, I would start topical steroid only when I see corneal changes or GPCs. Corneal changes, Horner-Trantas dots, or giant papillary conjunctivitis. These are my three indications for starting steroids. Without these three, I'll be very hesitant to start steroid. So if the patient is very symptomatic without either of these three, then I go for topical immunosuppressants like cyclosporin or tacrolimus. I've already told you tacrolimus is working better in my hands. You could use the normal strength on the eye, or if the patient is very symptomatic, you can use a higher strength on the eyelid. There is a recent publication in IGO
Yes,
which
ma'am.
shows
Yes, ma'am.
that
We can
the higher strength on the eyelid has got less toxicity and equal effect.
equal
So when
efficacy.
the patient has got GPC or corneal SPKs or active Horner antastors, then I give them topical steroids. So that is the next step. I bought myself several months and years in this process, since the point I started now, right? So topical steroid also, you give them a course and you reduce and look for the remissions and exacerbations. If it comes under control, then you overlap it with the tacrolimus and the other measures that I told you. And if it is recurring again and again, then I resort to what I call as a slow taper. Once it comes to one time, you make it alternate day, then you make it twice in a week, then you make it once in a week, and then you continue like that and taper, hoping that the second step of medications will take over. And then when you have allergy, which is very severe, not coming under control with any of these persistent shield ulcers, then you can go for supratarsal injection of steroid. And the last Brahmastra that we have in our hand is systemic immunosuppression. So that is how I would take up my step ladder approach to the treatment.
And ma'am, which is the dual action antihistaminic do you prefer to give?
So both these are there. You can use both alcaftidine or you can use olapatidine. Both are dual acting. So I don't have preference of one over the
Bepotastine as well? Bepotastine as
in
well?
my clinic, I use either of these two drugs more than
Alcafta or
alcaftidine or olapatidine.
Oropalatine. Thank you, ma'am. Thanks.
But just giving a prescription for olapatidine for 4 months really doesn't work. It has to be combined with all the other measures that I told you, avoiding putting a logbook, giving cold water compression, and coupling it at times when you want with steroid or tacrolimus. Is basically a juggling act. So, so that we keep things stretched over a period of time. At the same time, don't allow the allergy to get out of hand as well.
Ma'am, I wanted to ask you a question because tacrolimus usually takes some time, maybe around a week or 2 weeks to start acting. So in the absence of these 3 signs that you mentioned, I wanted to ask you this because typically what I do is along with tacrolimus, I start topical steroids and tapering doses of steroids depending on the inflammation. So do you practice where you will not start soft steroids at all and just give tacrolimus and wait for it even if the patient is very symptomatic?
No, yes.
To start acting?
Yes. In most cases, there is no hard and fast. There might have been an occasional patient where I might have started a topical FML, but my general dictum, Aikida, is it may be right or it may be wrong. Like to repeat myself, I treat the papillae and not the patient. Of course, it is important to treat the patient for their comfort and everything. But then if the patient's symptoms are too much and the patient's signs are very less, you can do fancy things like, taking a tear sample, looking for inflammatory mediators and all that. But then I would still not give steroid. I would not wait also because the patient has come to you for immediate relief. That is when the dual acting agent, the antihistaminic, starts acting very fast. The dual acting agent, cold compression, counseling, and tacrolimus. This is a very potent combination, more potent than we would like to believe if done in the proper manner.
Thank you, ma'am. Thank you so much. That really helped.
Because believe me, I'm sure you would have also seen so many steroid-induced cataracts and so many steroid-induced glaucomas. And the moment you give it, the patient feels comfortable, then they start buying it across the counter. So it is like, giving, what shall I say, a lighter to a child. You have to, make sure that it is really required for them to, have it and handle it and supervise it before you introduce the particular treatment to the patient.
Yeah, lots of times these are young patients who might be steroid responders also.
Correct.
Yeah.
So educating the parent, educating the teachers, avoiding playground activities for some time, and cold compression every single night. You have to reinforce it to them and give them the proper method of doing it also. Otherwise, they do it randomly the way they want. And the tacrolimus on the eye or on the lid skin. And for immediate relief, like you asked, dual acting agents. I think for most allergies, it will work. Here, I'm not talking about the extreme cases where they come back with, GPCs again and again with corneal problems. I'm not talking about that kind.
Right, ma'am.
Ma'am,
Why doesn't anybody else give their inputs? I mean, would you agree with me, or is there any other way you would like to treat a basic allergy?
Ma'am, what do you suggest as specific adjunctive therapies in both the conditions, which will help relieve symptoms in ocular allergy also and dry eye disease also, without exacerbating the symptoms of
So
one or
allergy,
the
I
other?
think I just now mentioned. Okay, I just now mentioned. The various things I would give as adjuncts along with the logbook technique also really helps. It may not sound like a very hi-fi adjunct, but believe me, when they come back in 3 months' time, they themselves are telling you that these are the conditions which actually exacerbate my child's allergy. For dryness also, rather than juggling this and the other lubricating eye drop, if you have a basic idea whether it is aqueous deficiency or whether it is meibomian gland dysfunction, because mucin related dry eye is very rare and it happens in cicatricial eye diseases, and those we don't treat in general ophthalmology clinic. We usually refer it to ocular surface practitioners. So if we exclude the wettability related dry eye because of mucin deficiency, then we are left with the aqueous deficiency as well as the ones associated with the meibomian gland disease. So taking a look at the lids, controlling dandruff, giving them lid cleaning. I don't prefer baby shampoo, just simple lid cleaning. And also teaching them about blinking exercises. Okay. Teaching them for computer vision syndrome, some basic steps like keeping an arm's length from the system, counting their, blinking times, taking a break of 5 minutes after 1 hour of work, distance focus and come back, keeping the illumination low on all the devices that they are using, finding out if they have any phoreas, any orthoptic exercises which will, benefit them. So we keep thinking dry eye, just like the patient. The patient has any features which makes them feel dry, they think it's dry eye. We should also not think in the same way. So it may be computer vision syndrome, it may be an orthoptics related asthenopia, which is compounding the, problem. So these small things, when they taught to the patient, goes a long way. Not only one time, they forget about it when they go home, they do it for 2 days, 4 days, and they don't do it at all. So when they come back with the same symptomatology, before they have a chance to complain to me, I ask them, how religiously they have followed all of these. And this associated with simple measures like I've already told you, blinking exercise, a small exercise which goes a long way in treatment, and also not sitting under the blast of the AC and not getting exposed to dry and dusty environment. These are small ad hoc measures which can help with the dry eye treatment. Here again, I'm talking about the simple aqueous deficiency which comes because of age or some other reason, post-viral conditions, and also about the simple meibomian gland dysfunction. I'm really not talking here about secondary Sjogren's, which is associated with significant tear deficiency or a cicatrizing eye disease, which is accounting for less wettability of the ocular surface. Because this simple group of patients form the bulk of your practice. So here again, no point in shifting them from one to the other anti-inflammatory or lubricant, mindlessly without addressing these basic requirements.
What about the role of omega-3 fatty acids and
you don't have anything to lose, so you can give it. It makes you and the patient happy. You can give it. But if you want to switch over to something more expensive or more long term, like say for example the new players in the game like levetiracetam or a different concentration of cyclosporin, etc., before doing all this, I would definitely give simple lid scrubs, blinking exercises, counseling for computer vision syndrome, and looking at orthoptics before I jump into any of these newer and more expensive players in the game.
I would like to welcome Dr. Praful. Thank you for joining us, our secretary.
Sorry, I'm a little late today. Sorry, I hope the lecture must have gone great.
Thank you, Dr. Praful. We had a good time both with the talk as well as with the discussion till now. Thanks for having me here.
Thank you, ma'am, for accepting my invitation. I think Ikeda, carry on your discussion part.
Can we have some other questions and comments, and also, different the way the other panelists are practicing, so that we can have a good discussion about the different kind of protocol that we are following in our clinic routinely for ocular allergy, and also maybe some pointers about differentiation.
So, thank you, Dr. Radhika. That was very nice and a very comprehensive talk on this thing. So, most of the studies that you see these days, especially in children, show that dry eye is around 30% to 60%. But in your practice, do you routinely get something like an ocular surface OSA or a dry eye evaluation done? And does that form a modality in your routine follow-up for children, especially?
So, as far as children are concerned, dryness in children, even though studies may say otherwise, is not very common even in a specialty corneal practice. Okay, because by definition, if you have an aqueous deficiency dry eye, those kind of diseases don't exist in children. Then there are some outliers to this. The kind of children that actually have dry eye are the ones with the rare group of congenital lacrimal problems. Okay, so you may have a sensitivity problem, or you may have a development of the gland or ductules kind of problem. So congenital problems can lead to dry eye in children. The other entity which leads to dry eye in children is recurrent herpes virus disease. When you have, there was a patient whom I referred to in my presentation also. That patient was actually a young adult or a child who had the combination of all three. He had vernal catarrh, and probably the chronic use of steroids exposed him to a recurrence of herpes disease as well. And both of them, led to reduced tear meniscus height, both because you can have infiltration of the gland, and the chronic surface inflammation blunts the corneal nerves, and a combination of these factors resulted in a dry eye. So if you recall that patient, they had BKC, they had dry eye disease, and they had recurrent herpes also. So this HSV recurrence is one reason why children may end up with dry eye disease. And last but not the least, vernal catarrh. We know that allergy is common in children, and what starts off as allergy, ends up with ocular surface inflammation, which again causes neuropathy as well as lacrimal gland dysfunction and can lead to dry eye. So apart from these three major entities, congenital, HSV recurrences, and VKC, I really don't see, dry eye like we see in adults in the pediatric population.
And maybe blepharitis would be one more reason.
Exactly. So we were talking about exactly blepharitis, and because these children may have meibomian gland disease, and not only children. When you go to the little older age group, young adults, they are a hormonally active age group, so they have this triad of dandruff in the scalp, acne on the face, and meibomitis, and that can lead to not aqueous deficiency but tear instability due to the quality and the quantity of lipid being different, and they can have dry eye-like symptoms as well. Here again, holistic treatment is required. So if you just give some lubricant drop, it's not going to get better. So better to refer to the dermatologist, because market shampoos, they only keep the dandruff control till the time you use it. So control of the dandruff, the acne, and proper lid cleaning, along with a course of doxycycline. Doxycycline not recommended in small children, but children who have outgrown their growing age group, that can give a certain amount of relief. Yeah, that is one important entity in the pediatric group, to answer her question.
Also, have you in your experience seen a lot of Demodex that is associated, since you mentioned blepharitis? So we routinely would do, and if we see those cuff, like we routinely do a lot of flash testing, and we do significant amount of Demodex that is associated.
Correct. I'm glad that you mentioned Demodex, because there are two answers to this question. The first answer is, I think you've answered your question already, that when you see the collarettes outside the lashes and corresponding changes on the ocular surface, typically you see those perilimbal changes with vascularization also. Because if you see just staph immune disease, the vascularization is not that much. When you have Demodex related ocular surface or corneal changes, it comes with vascularization also. So there you can, remove the collarette and examine it. You have to remove it very carefully, because I remember one time I asked a resident to do, and then they broke it up, and when we put it under the cover slip, we had a dismembered Demodex over there with no legs or hands, whatever. So if you remove it carefully, you can see and you have to kind of rush to the microbiology immediately, so that you can see the, nice live Demodex dance over there. So then you can treat the patient with both scrubs and tea tree oil, and treat the ocular surface also with some weak steroids, and get over with it. But then there are 2 points I want to mention. First point is that for tea tree oil treatment, you have the possibility of in-office reconstitution of the oil itself, and you have the wipes. So if the patient is doing it at home, better to give the wipes, because if they don't do the reconstituted treatment properly, there was an article in Cornea Journal where they came with corneal epithelial defect and toxicity to the cornea. So if it is got to be the solution, then it better be an in-office treatment. That is one point that I want to make. The second point I want to make is that not all Demodex is problematic, because we must scale back and remember that Demodex is a normal commensal. So just because we are seeing some kind of a dry eye disease, you immediately pluck off some, scrape off something from the eyelid, you see Demodex and you don't want to start treating it, because Demodex, any normal commensal, when you upset the balance, you lead to, colonization of other organisms. So only when you see the collarettes, only when you see the ocular surface changes does Demodex require treatment. Otherwise, the mere presence of Demodex on the eyelashes is not a cause for concern or treatment at all.
Ma'am, what is the role of, now we have, these cleansers with tea tree oil as well, apart from the wipes. They are available now in the market. So apart from tea tree oil wipes, because reconstituting, I understand it's not a great idea to tell the patient.
Patient,
Can we
yes.
prescribe, do you routinely prescribe cleansers with tea tree oil, just like we have cleansers for normal blepharitis for patients with Demodex?
So I really don't have a contrasting experience between the two. So the patient gets whatever they can order off Amazon when they, want to do it. So normally what we do is we refer it to our ocular surface colleagues. We remove the collarette, and once we prove the Demodex, our ocular surface colleagues are nice enough to do the in-office treatment for a few days till the patient is around the place. And then we follow it up with either of the two, the scrubs or the wipes, whichever the patient can lay their hands. So that most part of the treatment is taken care of. Like, you manually removed it and they have done some in-office therapy. Now it doesn't matter which one the patient continues.
Ma'am, patients who need steroid-sparing immunosuppression, that is tacrolimus or cyclosporin, what is your end point? How do you decide that now we can discontinue them? Because sometimes they're on cyclosporin for quite a few months and then you stop them and they come back to you again.
That is a very good question. That is a really good question. There is no end point, because we know that allergy is a long-standing problem. The allergy doesn't grow out of the patient. The patient has to grow out of the allergy when they go into adult life. And like I mentioned, there's a small but sure subset that continues into adult life also. So that is why I prefer tacrolimus, because even that little bit of ocular surface toxicity that I see with cyclosporin, I usually don't see with tacrolimus. And tacrolimus, if it is causing some toxicity, you can apply it on the lid skin. But one word of caution here also, even though I've really not seen or read a paper about it, tacrolimus comes with a caution. If we read the fine print, over a long period of time, it can cause epithelial neoplasia. So theoretically speaking, we incur a risk of OSSN if we use it for a very long time, even though practically speaking, that risk is not there. So the reducing or the stopping of tacrolimus happens in a situation where the patient is symptomatically better. Your ocular signs of allergy are better. It is a good season for the patient. Means it is a cold season where the patient usually does not have too many, relapses of the disease, and you give copious lubricating eye drops, and the patient is willing to come for follow-up to see the withdrawal effect. If all these ands are combined, then you may withdraw tacrolimus. It's no big deal to stop the tacrolimus for 4 months and then restart it also. It's not an all or none like steroid that immediately you don't want to give it. You just withdraw tacrolimus for a few months, and then again after a few months, you can restart the tacrolimus also.
Ma'am, same thing I wanted to ask.
Problem, keeping in mind the caveats that we spoke about.
Ma'am, same thing I wanted to ask you about the contact lenses. So what is the endpoint? When do we say, okay, you are not suitable for contact lens usage anymore? Or suppose if there was allergy and it has subsided, so how long should we tell them that, yeah, you should be off contact lenses for few weeks, and how, what should be the ideal?
So the thing is, just like allergy, I believe that for contact lenses also, a lot of homework has to be done from our side and from the patient side. Okay, a lot of contact lens problems stem from the fact that the patients have not got it from a proper laboratory or a proper institute. They've got it across the counter. Or the putting, removing, cleaning, maintenance, they're not doing it properly. Or the solutions are not proper. Or they are not coming for follow-ups properly. These are the 4 main reasons why patients start developing problems with contact lenses. Let's not include infection in this discussion because that is not the topic over here, even for allergy. So we make sure that it is got from an institute. Why does that help? Then the power, fitting, material, everything is reviewed before giving it to the patient. We also emphasize the usage part. They don't wear it with dirty hands. They don't sleep with contact lenses. They don't mismanage the solution. That again takes care of a large chunk of problems that can lead to development of allergy. Third, we ensure that they come for follow-ups properly every 4 months or every 6 months till we know that this patient is responsible enough to handle contact lenses. So if you do these 3 things, then you cover a large chunk of allergy-related problems. Over and above that, if the patient develops allergy, as long as there are papillae or corneal changes, there is strictly no use of contact lens. However much the patient insists to you, however much they are going to be irritated or upset with you, no contact lenses. So here, if it is a contact lens or a contact lens solution related allergy or GPC, like we discussed in the earlier slide, it is a response to an inorganic substance. The moment you abstain, it will become all right over a period of time. Unlike your vernal catarrh or atopic keratoconjunctivitis, where that is not the case. So once the patient has recovered completely in their ocular surface, then we can, with these measures of caution that I told you, we can reinstate the use of contact lens. On the other, every coin has 2 sides, right? On the other end of the spectrum, you have these severe allergic conditions or severe dry eye diseases which require refractive or visual rehabilitation. In that end of the spectrum, we have even used PROS contact lenses. So PROS contact lenses cannot be used when the allergy is active, but when the allergy is to some extent under control and you have surface scarring or discomfort, which are difficult for the patient to handle, then you can give PROS contact lens. Why? Because the liquid film which is there between the corneal surface and the lens helps in 3 ways. One is it helps in better fitting of the contact lens. It helps in better comfort. The cushion gives better comfort for the patient, and it also gives better clarity to the patient. So both in extreme dry eye disease and ocular surface changes which preclude vision in allergic diseases, we can give PROS contact lenses. That is at the other end of the spectrum.
Yes, ma'am. And PROS really helps in patients who have associated keratoconus along with VKC as well.
Exactly.
So only problem is I've seen a couple of patients where the turbidity in the fluid comes a little more frequently for these patients who have recurrent exacerbation. So sometimes initially it takes them a long time, much longer than the other patients to get comfortable with those PROS contact lenses.
Yeah, so that is the word of caution. So we spoke about dry eye, keratoconus and allergy. But mind you, the allergy has to be under some amount of control,
Right.
even for the PROS contact lens to be given. So there are 2 types of situations where you have burnt out GPCs and you have surface scarring. That is where you want to give these lenses. Not with active GPCs and Horner transducers. In those patients, if you go and give PROS contact lenses, then it can become counterproductive. It is like a blocked wash basin. Right? So the fluid with all its turbidity and inflammatory cells gets caught under the PROS lens, and it can only renew once in a while, and you may actually, exacerbate the situation. So why doesn't anybody else tell me, in cases of these mild allergy or mild dry eye versus the severe ones that we discussed, is there anything else that they do differently? Or, any other thoughts? How about you? Let's start with you, Aikida. Anything else that you do differently?
Ma'am, like you rightly said, I usually start with a dual acting agent, or I might give nidochromal sodium if it's a long standing, especially in cases of perennial allergic conjunctivitis, which might require a long term agent. Alcaftadine I tend to use where it's more of a seasonal allergic conjunctivitis. I tend to give it for a shorter duration of time and then give lubricants along with it and cold compresses, like you rightly said. And probably for more perennial cases, I do like to put them on nidochromal sodium and sodium chromoglycate, one of those compounds, and then continue it for a long period of time along with lubrication. That's for the milder cases is what I do. And typically I sometimes always tell them, I ask them that can you just maintain what time of the year you get these exacerbations, and then probably come to me a couple of weeks earlier than that so that we can just restart the therapy if needed once it has subsided, so that they are more comfortable and they understand that really well. Lots of these patients who have SSE also know that this is the time they are going to get an allergic exacerbation. And I think that works really well if you start them on that treatment maybe a little earlier, at least just pure lubrication, and tell them to start with cold compresses so that it doesn't get to a point where you need to keep giving them soft steroids again and again.
Correct. And how many in the panel routinely resort to testing for inflammatory mediators in the tears, or putting the patient through an allergy panel to, or an allergy specialist to, find out the agent?
Ma'am, I've done it a couple of times, but mostly it has been come out to be very non-specific.
Exactly. That's
Like
why I feel the
in
logbook works best.
resistant cases, twice or thrice I've got it done and sent them to skin special allergy clinics, which they have, and they run a battery of, they test with various
Quite
compounds.
often the correlation
It's
is not
usually
there.
very non-specific.
If it comes as positive, you can take it, but if it comes as negative, then we are again back to square one as to, and I don't believe allergy is to one thing. It is a complex. Basically, it is the environment rather than one individual thing in the environment. So it helps to, understand from the patient's perspective as to what the trigger is rather than doing the tests, unless it is absolutely indicated in some cases.
Yes, ma'am. So basically, they test with almost more than 50 compounds, and in very few of them it will be ticked. So it's hardly, we can't actually go, and it's not practical. I mean, I don't think it's that practical for us.
Correct.
And yes, I just wanted to add regarding the cyclosporin strength. So I've used, instead of supratarsal triamcinolone, what I do is, because it's little bit invasive, it's an invasive procedure. So if instead of that, if we give cyclosporin 2%, like I get them purchased from the pharmacy, and I'll reconstitute it myself and I dispense it. That they have with those, I've actually seen the giant papillae melting. They
Correct. Provided the patient can tolerate it. There is a segment of patients who can tolerate this, then you can use.
Yes, ma'am. Initially, they might say that they are not able to tolerate. Once the response sets in, then they are very, very happy with it. So that is bitter.
In tolerant patients, you can definitely use it.
Yes.
But in intolerant patients, the lower concentrations, I really don't find them to be any effective.
Yes, ma'am. Lower, they don't have any effect.
And now with the influx of medications which are anti-inflammatory, like levetiracetam and all that, with the amount of market zing and cost attached to it, I really don't know whether we should scale up on our testing of the tears, or scraping of the papillae to look for inflammation. I really don't know if those things work at all or not.
Ma'am, have you used liftigrast in patients with allergy as well? Since we are talking about
I used up the samples that I got. I really don't believe in it that much at this point in time and making them invest on it themselves. I've just simply used up the samples that I've received, and the time period now is too short for me to give a realistic feedback.
Are they conducting any studies on it, like in Shankar Netralaya or anywhere? I mean, so are there any studies going on
before we probably will. We have a dedicated ocular surface team who is looking at allergies and dry eyes and and their responses to these anti-inflammatory agents. So maybe in the near or distant future, we will look at it. And studies are, really speaking, the only way that we can make the medication affordable to the patient at this point in time. So unless and until we convince ourselves through comparative studies, we really cannot tell them to purchase the medication. So once you do a study, the medication will be given to them free of cost, and maybe we can find out something. But then in the same, I'm somebody who, for the better or worse, is a very basic person. So, rather than MMP kits, I'm not saying that they don't have a role. I'm not reducing the value of the test or the people who are doing them. But then there's no point in not concentrating on the clinical appearance and going in for these tests. There is a simple sign which, when you see on slit lamp, you can make out in some of these patients with dry eye or VKC. You can even see it in patients who have reflex tearing in dry eye, where if you look at the tear meniscus, we don't only look at the height, but you can also see some fine, oily, powdery deposits sometimes. Okay. The line of marks is, littered with that, whitish deposit. I wish I had a slide to show it. If you look carefully, sometimes you can see it. If you can see those powdery deposits, then quite often you can be assured that there is an inflammatory component on the ocular surface. So probably those are the, I could ask me a question whether when you don't have SPKs, when you don't have GPCs, when you don't have a shield ulcer, will you still start steroid? So if I have a definite indicator of ocular surface inflammation like this, then probably those are the rare cases. Without those triangular signs, I will still start steroid. That works better than any MMP kit form.
Right, ma'am. I also wanted to know any specific indications for oral immunomodulation in these patients, and what is your preferred agent? How do you decide whether if it's not responding to all of these agents for how long? Then is when you take the call that okay, this patient needs oral immunomodulation.
Very rarely those there are those children with VKC who don't respond to anything at all. Absolutely. Then you may want to, with the physician clearance, give oral steroid or even immunosuppression like Azoran or something like that. Very rarely, because you must also remember that this is the peripubertal age group for them, and both steroid and immunosuppression will have an effect on gonadal development, fertility, and all those things. So in the rarest of rare situations, yes, we have given both oral steroid few cycles as well as Imuran and other or even oral cyclosporin.
So just to answer that, we had a very big data which we took out from 2-3 centers, and we had over 1,200 children who were treated for VKC, specifically
Okay.
VKC. And out of that, they were all referrals. I mean, referrals from secondary centers, etc. But we did have 19 patients who needed systemic. But in that large number, I think this is, and these are patients who have presented to us, say at 13, 14, largely not treated, and now have come with significant limbal stem cell deficiency.
Correct.
Or non-healing shield ulcers, something like that.
So what was the agent that you used, and how long was that used?
So we have used systemic steroids, like pulse systemic steroids, when we've seen them. And if we know that, like the patient is going to be with us for some time and then, stay in Delhi and then go back. So we have used systemic steroids. We have used oral cyclosporin and also oral tacrolimus, depending on affordability. So these are the ones we've used. But yes, it's a significantly less number.
Correct.
And just to answer the other question, as a research, we have been doing a lot of tear film analysis, impression cytology, and IVCM. That's not really for diagnosis, but that's mostly for the research, because one of our scientists has a DBT grant on VKC.
Correct.
In that, what we have normally seen is, yes, inflammatory markers, which is very significantly high. We have also had patients that we have treated on steroids and patients who were not on steroids. We have done impression cytology to see what their like the first 2-3 layers of epithelium is. So even patients on steroids have presented with significantly high fibrosis. So that is also an outcome of giving long-term steroid, because we feel that it is kind of reducing the scarring. It will reduce inflammation long-term, especially limbal fibrosis. If we have taken a sample from the conjunctiva as well as the overlapping the conjunctiva as well as the cornea, limbal fibrosis is a very significant outcome again of steroids, long-term use of steroids.
Right. That is a very interesting finding. So normal perception is that not only reduces the inflammation, it reduces the scarring also. There's a premise with which we give it even for resolving bacterial keratitis and all that in the stage where the antibiotic has gotten control of the disease. But then if you find that the limbal scarring, I had shown you a patient where virtually the papillae and follicles had taken hold of the limbus, and the final LSCD was looking like an ocular surface disease secondary to a cicatrizing, problem. And who knows that some part of it might have been contributed by the steroid, also going by the findings that you shared right now.
So that is, I mean, basically what we have been looking at is the fibrotic markers, the markers for the conjunctival markers and the fibrotic markers, and they are significantly higher in patients on long-term steroids.
And the occasional patient, we've not been doing it as a study or anything. The occasional patient whom we have subjected to confocal microscopy, especially in dry eye associated with Vernal, was that the most important findings were the reduction in the subbasal nerve plexus and the abnormal branching patterns and the presence of dendritic cells. So were these also the findings that you saw, or did you get any other outputs with the IVCM?
So one, what we have seen is discontinuity of the nerves. Like you mentioned, the reduction in density of the subbasal nerve plexus. So these patients, the continuity, again, the same thing that you see, the reduction in density is what we've seen. We have also seen dendritic cells, because again, the surface inflammation it is very and these findings of VKC, IVCM are again very similar to that of dry eye.
Exactly.
It is the surface inflammation which is causing these changes specifically.
Correct.
Very similar, because IVCM now a lot of people are doing, and we have also tried to grade it for VKC, but then it's not very significant. So it's not really a test that routine.
So it is believed that the surface inflammation affects the corneal nerves, it affects the limbal stem cells, it affects the lacrimal gland and the meibomian gland. So I think eventually it leads to a dry eye-like condition.
Thank you so much, ma'am. Do we have any other comments from the panelists? Any other questions or comments or anything to add? So I would like to conclude the meeting. Thank you. Thank you so much, ma'am, for such an insightful talk. I think we had a very fruitful discussion. Thank you to all the panelists for joining us today and adding to.
Thanks a lot to you, Aikida, for the effervescent enthusiasm with which you coordinated the program. And I learned a lot from the panelists, both from their perspective, and when you answer their questions, you think back as to what you do in the practice. So I always believe that the speaker benefits more than the audience, and it has been reaffirmed this time also. Really want to thank you and Praful and DOS and all the panelists for being over.
Thank you so much,
Thank
ma'am.
you so
And
much, ma'am.
I really appreciate Ekada. Ma'am is up of bang on right that you really conducted this so well. And this is one of the best webinar series in our dry eye clinic so far. Thank you, Ekada, for that. And again, we have a very good audience today. We have almost 211 live viewership at any point of time. So that's again a very good number for us. And thank you, ma'am. And the talk was really awesome. When I learned a lot of things. And thank you to all the panelists.
Thank you. Thank you so much. Can we just take a quick photograph? I'll click it with my phone and we can conclude. Thank you so much. Thank you. Thank you so much, Dr. Praful, for giving me the opportunity. And thank you, ma'am. And thank you, all the panelists. Good night.
No, that's all webinars you are only going to do. So don't thank me.
Sure, it's my pleasure. Thank you.
Thank you. Bye.